Good morning, everyone. Very enjoyed it so far. First of all, I would say who we are. Well, my name is Rhodes. I was a risk and insurance manager for a large metropolitan borough council till I retired. Why am I involved in PPI? Because I wanted to do something that would be helpful, also engage my brain, because I got involved in doing reports in my former life, and it just seemed a very worthwhile thing to do. And I was enjoying it. We've been doing it now for 4 or 5 years, and there are improvements that can be made. We'll talk about that later, but so far, so good.
Good morning. My name is Brett Collard. I'm a retired engineer. I was recruited into PPI the day I was being discharged from Papworth Hospital following a heart attack. And at that point in time, I wasn't taking a great deal in, so I said, yeah. I went along to an event that had been organised in Cambridge somewhere, I was lost in the missing time. And I sort of grabbed onto this because I am by nature quite, some people say nosy, I'm inquisitive, I like to know what's going on. And I felt maybe it was time for some payback. I was taking early retirement following the incident, dreaded having time on my hands that wasn't going to be useful. So this came along, and this is one of the things I've got involved in. I do get a great deal out of it. Sometimes it's nice, it really is nice to get an email back from a researcher and say, thank you for that input, even if they say, we can't use it, it wasn't very constructive or whatever, but any feedback is great. And it does fulfil that aspect of social payback when you're in retirement years. Please don't think you've got to be retired to get involved in PPI. You don't. It'd be nice to have younger people in.
Okay. Right. We're now going to the next bit, the project we're involved with. Both Brett and I are involved in the same project. We call it the knee fix. Basically, the idea is that they're aiming to investigate 2 ways of treating fractures around the knee in elderly patients. At present, both young and old patients with this type of fracture are most commonly treated with surgical fixation that involves plates and screws, and called the ORIF. An alternative option to fixing the fractures is to replace the knee and bottom of the thigh bone with an artificial prosthesis that will perform the function of the knee instead. At present, there is limited evidence as to which technique is better with regard to the healing of the bone, knee, function, quality of life, and time to return to the usual residence. There is also a significant cost difference between the 2 forms of treatment. There are involving people with dementia. On the first one, with the screws and the knee fix, the patients are required to be not put any weight on their knee for the first 6 weeks, whereas with the second, more or less patients can walk around fairly quickly. They are involving, on this research, people with dementia. And sort of one of my first comments was that as the people with dementia are more prone to likely to forget that they haven't put the weight on their knee, they're more likely to suffer the further damage to their knee by putting the weight on it. But they say that the question that came back to me was, yes, we have to include people with dementia as they are part of the overall group, an inclusive policy. The first thing they did was that the researchers asked us to look at what they call a patient information sheet, which is what they will give to all the people they're trying to involve in the study. And without going into a great deal of detail, but on the first page it says, you have been invited to take part in a research study. Before deciding whether to take part, you need to understand why this research is being done and what it involves. Please take time to read the following information carefully and talk to others about the study if you wish. My first question was, who are the others? Your doctor, your friends, your relatives? It doesn't say. I mean, I'm not sure that needs to be clarified, but I raised that issue. The other part it says here, it says, take time to decide whether or not you wish to take part. but there's no time limit. 3 weeks, 6 months before you decide. I think they need to clarify that a bit more. And the other thing that I went back to the researchers and I said, one of the things I think you should put on here is a thank you. So basically saying, we thank you for taking part in this project, and as a result of this study, you will greatly assist the patient's well-being in the future. And I think if you're asking patients to take part, I think it's important to thank them for taking part and making certain that it's quite sort of humanised. So that was certainly one of the involvements, and the researcher came back and said that they'd taken a lot of the suggestions on board. Over to you, Brad.
Well, the original concept came to us as 2 foolscap sheets, a lot of reading to read through, but it immediately ground me out that if you have an empathy with some research, that helps tremendously. You've got to make it attractive, and get the person's attention. We, after some discussion, reduced all this 2 foolscap pages to a couple of simple paragraphs. That says it all. And it says it in language that any of us can understand, even me. One way to put people off assisting at PPI is to present something that hasn't been thought through. An example of this, I'm probably going to stumble over it, this appeared as an email, randomised trial of Ilumimab versus standard of care for the treatment of idiopathic membranous nephropathy. And it goes on like that, for 3 solid paragraphs. I'm sorry, I'm an engineer by trade, tell me what it means. At that stage, you would have had to have someone sit down with this research and say, let's put that into language we can get people to understand. It may well be a fantastic piece of research. I just did not understand it. I wrote back to Andy at the time, so my response to this was, I'm sorry, I don't understand it. I can't really respond. He said, just put that in writing to me and I'll get that back to the researcher, which is what I did. That's an example of how not to get respond. The knee research, we've had lots and lots of interaction with this. It really did gain some momentum, and every step of the way we got feedback. In fact, yesterday I spoke to the lead research, and this research is going to go ahead starting in June, July this year. The I's have been dotted and the T's crossed, and we're all looking forward to that. There were a few simplistic suggestions we made. Some of the language used, Graham's already referred to patient participation sheet, referred to radical treatment or radical replacement of need. It's a bit scary to some people, but how about, we've got a new type of need we'd like to try out. You've got to empathise with people, you'll give them an opportunity to take part in something that they can look back and say, yeah, that was useful, well, I did that. But also explaining pitfalls along the way. So a lot of our input was into recruiting people into the research programme by making it attractive to them. They're in a position, they're in severe pain. They need to make a response fairly quickly. Graham's already alluded to the fact that we have people with cognitive degenerative problems. The original patient, the information sheet, it said that they wanted the patient to make that decision. That's not always possible. The alternative given were quite long-winded, and it went into several tick box scenarios which I detest. So we suggested how about making it who the responsible person is, who the carer is, and let them decide what their relationship to that patient is. At the end of the day, the surgeon can always make that decision if someone's not capable of doing it. And that was taken on board, which again reduced the patient information sheet by quite a substantial amount, a lot easier to read. So all in all, I got quite a buzz out of this, and especially getting an email yesterday, the timing was perfect, to say that it's all moving forward and thanks for your input. That's my opinion.
I mean, going on from this, I mean, in the patient information sheet, there was a sentence which said, in the event that something does go wrong and you are harmed by taking part in the research, and this is due to someone's negligence, then you may be able to claim compensation against the hospital. I think that's really encouraging, don't you? And I just simply said, I don't think you need to put that in.
Standard conditions apply.
And the other thing, it said, the commercial company are providing the distal femoral replacement sets free of charge for use within the study. The company have no influence over the conduct of the study or the data that will be generated. Again, I don't think that needs to be in. because obviously having the commercial involvement is not really relevant to the patient information sheet. And they also said that the doctors aren't getting paid for this. Well, okay. Neither are the PPI people. So from that point of view, again, these just little things here that from a patient's perspective, it's something that researchers, I mean, I've written reports myself, and sometimes it's difficult to see how other people perceive what you've written. And I think, I mean, one of the suggestions I thought of was that maybe when you're doing research, maybe you should, if you want to ask your friends or your parents or your grandparents, what do they think of this lay summary or the summary at the outset, because they're quite good. I mean, we're no different to anybody else. We can see it from the patient's perspective, and so can they. So I think that's quite a good thing to do, just an idea. Again, I think Brett also alluded to relevance. One of the projects I'm involved with is weight study. And what they're doing is that they're going to have people going on a free Weight Watchers program for 12 months, another group going on a free Weight Watchers program for 6 months, and another is just seeing their doctor. And the research project is about cost effectiveness of the 3 treatments, or how effective they are. Now, I may be cruel here, but I think to me, if you're going on a Weight Watchers program for 12 months, you're more likely to lose weight than if you're just seeing your doctor every other month. So, to me, what relevance was that? The research also said that the results will be studied after 2 years. Well, in my experience, people who have been on a Weight Watchers program for 12 months can very often, after 12 months of not doing anything, immediately put their weight back. I said at the time that I think it's more relevant to have a study into the motivation as to why people put the weight back on. Is it to do with the fact that they think after they've been on a 12-month weight loss program, they don't need to do anything else? And I think if they centred the research on that, I think that would be of more relevance and it might help things. So that was my comment on what is relevant. Okay?
Really valuable insights and studies. Thank you very much,
Okay.
Graham. Have you got any questions? They've both got extensive input into different research studies as well, and excellent examples, so please feel free to ask some questions.
It was more a comment rather than a question, because I've filled out patient information sheets, and I agree with you about there being loads of things. You just think it just sounds like terms and conditions, like you were saying. And I just thought that what you both said kind of highlights that perhaps the patient information sheet should be divided into essential information and then have those terms and conditions perhaps at the back so that you know where you should focus your reading.
So I'll make one comment, which is, in fact, I'm involved in a clinical trial that uses this drug belimumab that you mentioned, but not that particular one, but one in transplantation. And I would say that the transplantation patient information sheet is even worse than that one. And what we've been limited by is actually the drug company who mandate that we put in a whole lot of information which I would consider to be not necessary. So actually we've as a researcher been hamstrung by that, and I the one in the transplantation one is so long it's really not workable, but we're actually being limited by the drug company. And then the second thing is a question, and perhaps slightly mischievous maybe. Do you think it's possible that, so we heard from Doreen and Andy about training for people that are involved in PPI. Do you think it's possible that you can be so trained as a member of the public or a patient or be involved in PPI for so long that you no longer bring a lay perspective? So actually you're a professional PPI person. And so I guess the question for that would be, do you think that involvement in PPI should be time limited so that you've always got people to bring in a fresh, truly public lay perspective?
That's a very good point, and some of the people where my members are retired NHS professionals who speak a different language and understand things. They still bring things to that PPI group. Quite often they're able to be that intermediary between the problem you have with the drug company saying we must use all this jargon, and me, the lay reader, who's going to try and understand it in plain English. And there has been, even though they're quite highly skilled and qualified people, that they do fulfil a role. I think the day that I probably know enough or too much or anywhere near enough is a long way away to carry on stop me having a useful input into PPI, so God forbid that day ever arrives. But it is a valid point, and I think if those retired professionals had it away, perhaps there'd be fewer lay people involved. I don't know.
I think also that I look at it, when I get the information, I try and look at it from a patient's point of view. And very often, a lot of the projects that I reply to are conditions I've already got. I mean, I've got a knee problem, so I identify with this knee fixation. There's another research was done on exercises for diabetic people. Again, I'm borderline. So in that way, I can relate to it because I'm going through it at the moment. So maybe, yes, and I think that I certainly try to look at it not from my perspective, but certainly from a patient's perspective. I'll try to. So that way you can keep...
I just wanted to ask you, do you have access to the group of patients that, like a study on the fracture thing that you have just mentioned? So do you have access to the group where you can go and discuss this about the treatment or the research which is being done?
No. We don't not directly with the patients.
Why I was saying, there was one comment, because when you're saying that you're involving the patients of dementia, really what they haven't mentioned is the category of dementia. If they are at the extreme, is that consent viable?
I mean, when I come into about dementia, it just seemed to me that that the study was going to just randomise 23 patients with fixation and 23 with the full knee replacement, irrespective of whether they got dementia or not. But I just simply made the comment that if the people with dementia are more likely to step on and not realise they haven't to do the weight, and therefore, if you're trying to decide which is the better treatment, you could just simply use people without dementia. The researcher did reply to that.
I was just going to say, Brett and Graham, often you're in mixed groups anyway, aren't you? And sometimes it's the skill that the facilitator brings to that group. So you might have Graham and Brett as very experienced PPI people, and I think this comes back to the question that if I had a new member from Inspire or another PPI group, it's excellent to team them up with Graham and Brett, because it acts then as sort of like a buddy scheme, like a mentorship, and then they can learn. So the inexperienced people can learn from the very experienced PPI people, and sometimes you have people with the conditions, so dementia, and often Andy and Doreen will get a mix of those people who are asked views from different groups with the questions that are actually being asked. And actually sometimes it's the researchers themselves that provide those participants. Often they will say, is there anybody that wants to be involved in a focus group? It's a very good place to start, isn't it? So,
can I just add a comment to the gentleman's question there? This particular group of need, no, we haven't met the group of patients, but in some studies we do get to meet patients. In some studies, having shown some interest, we're invited to join a steering group if we're prepared to do so. And I'm involved with a couple where I do sit down with patients. One is nutrition in older people who suffer with cognitive degenerative problems, and we do have a couple of people who join the group who are active. They are sufferers and they're active members of that group, and we take their feedback as well, and they quite often surprise us with what they've add to it. And it's always nice to have that. In the early days, it's getting that interest in the early stages of PPI. Is real interest there. In this case, the steering group hasn't yet been formed. I'm invited it will be formed in June, July when it moves forward to the next phase. It is a feasibility study, it's a fairly small scale study at the moment. So my name is down. Would I be interested? Yes, I would. I'd like to go forward with that. Because you can amend your opinions as things move forward. Things change. That's a good idea. I don't know where that's going. You say so. And at the end of the day, we've got to remember that the researcher can read what we've written or listen to what we say. They don't need to act on it. It's entirely up to the researcher how they want to model that. But if they want to say, yes, we're taking PPI, as part of the submission is, have you consulted PPI? Yes.
I think those changes are very important as well, aren't they?
Oh, yes. Because you get more understanding, you get more into the project. Currently I'm involved in, I've got 17 on this list here. That's the last 18 months. It's not full by any means. Some of which are going very, very quiet, some of which are very much alive. And it's that variation, I think, that keeps things very interesting for us. It's not the same old, same old. You never know what's going to come through from Andy, from Jessica next.
I also think, just finally, that getting involved with the research design service as well, which I attend once a year, and I attend their training, and they provide 3 studies that's been led by a research advisor, and I give a PPI perspective. But I find those sessions very interesting, listening to what the researchers advisors say about the project, and then obviously I come in with mine. So again, the more that we meet, not just certainly the patients face to face, but the researchers face to face is good, because we get to understand a bit more about your perspective, and hopefully you get to understand more about ours. So I think we need to do more face to face with research.
It's very much a PPI community, isn't it?
Yes.
Really. So in a two-way process. Thank you very much. Brett and Graham will join us again at the end of the session. So if you think of any more questions, perhaps then thank you very much.